this is some Q&A. We're here in this Zoom together. You'll be able to interact with Dr. Ward and one another.
Perfect.
I am going to open us up in the word of prayer. Any brother want to open us up in the word of prayer? You know, oftentimes we'll just call on something. I'm gonna open up the floor. Anybody want to open us up this morning with a word of prayer?
I'll do it.
All right, Ms. McGee, thank you so much.
Thank you, Lord, for this opportunity to come together, men that are looking for the best in their health. We are grateful for this opportunity to share. We're grateful for Dr. Ward and the wisdom he's about to share and how keeping black men and open our minds and hearts that we not only may receive, but enact what he's about to share. In Jesus' name we pray, amen.
Amen.
Amen. It looks like we are all internal to the New Salem family, but in case somebody watches this online or a rebroadcast, we are coming from you, New Salem Baptist Church in Columbus, Ohio. I'm Reverend Landon Adams, our Director of Membership. We also have Brother Adam Troy, who is our Director of Missions, our community and outreach arm of our ministry, is going to be with us today. He is a member of our congregation and a board certified urologist with the OSU Ohio, here in Columbus, Ohio. We appreciate him giving his time and talent. Our pastor always says, what we need is in the house. It is in the fellowship. It is thankful, Dr. Ward, today to talk to the men about our health and knowing our numbers. So we're going to kick it off and hand it to you. I've got your PowerPoint, so I will share as you are ready for us.
Okay, I'm ready. And as you all heard, I'm a urologist. So when I saw the title, Knowing Your Numbers, and I saw things like hemoglobin A1C and cholesterol and blood pressure, those are a little bit out of my wheelhouse, but those are all numbers we should all know. And from a urology standpoint, it's going to be your prostate-specific antigen, your testosterone, and everybody's hearing a lot about testosterone these days. So we'll talk about that. That's very important. And we'll talk about prostate cancer, which really is going to affect 1 out of every 8 men. And if you have a family history, it'll be a higher incidence. Now, certainly you want to know these numbers, your hemoglobin A1C, which is a reflection of your average blood sugar. So it's a test that doctors will give for diabetes screening. And it's better than a spot glucose, because the thing to remember is that any man's blood sugar can be normal, or any human's blood sugar can be normal, even if they have diabetes. If you haven't eaten anything, your blood sugar could be even low when you have diabetes. So the hemoglobin A1C, it's kind of you think of it as an average blood sugar over about a 90-day period. And so they assign it a number, and that's a number that, it's important to know as well. And cholesterol is a part of your lipid profile. I won't get into that much since that's not in my area of expertise. And then blood pressure, of course, everybody knows about that. But globally, it's just important to be connected with your primary care physician so that these things can be monitored. Think of the primary care doctor as the quarterback. And the specialists are the position players. And so the quarterback calls the play, kind of the quarterback coach, they call the plays, and the rest of us just kind of do our part. And so every person really over the age of 20 should have a primary care doctor. A lot of young people mistakenly, they feel invincible, they feel fine, therefore they're convinced they're healthy. But we see so many people, young people, who actually have health challenges and don't know it. And silent things like diabetes, hypertension, even young folks can develop cancers. And if you don't see a physician, some of the telltale signs that happen early won't happen. So that's why it's so important to be connected with a physician. So let's go ahead. Now I'm going to focus on my urology slides because that's my specialty. But I'll do it in a way that you guys don't get bored and fall asleep. So this talk was put together with some basic major men's health. Next slide. Men's prostate cancer, every man needs to know about that. I would bet you every man watching this or who will watch it knows someone who has prostate cancer. or has prostate cancer themselves. As I mentioned, 1 in 8 men will get this. BPH stands for benign prostatic hypertrophy. That's just getting enlarged prostate. That's not related to cancer. And again, if you live long enough as a man, you will get an enlarged prostate and start to have some of those symptoms. And I'll kind of, go through these quickly and go through the details as we move on. Erectile dysfunction, everybody knows about that. Low testosterone, that's a hot topic these days, is testosterone. What we now know is that having a better testosterone is more than just improving your sex drive. It's important for your energy, preventing fatigue and tiredness that's inappropriate, mental acuity, bone density, muscle mass maintenance, losing weight, losing body fat. If you're walking around with low testosterone, all of these things can be attributed to that. So let's go to the next slide. Quickly about prostate cancer. Everybody knows what a prostate is, and I think we all now know there's no R in prostate. That's a biblical term, prostrate. It's typically about the size of a walnut, but it can be the size of a plum in some men. That's what we call a very large prostate. It's a part of our reproduction. The semen, the ejaculation fluid a man has, comes from the prostate. And that's the purpose of the prostate. The semen carries sperm cells. Most prostate cancers are what we call just idiopathic. We don't know there, but 9% of the cases you inherit. So know your family history. That's my other take-home message. Know your family history, not just about cancer, but about any kind of cancer, high blood pressure, diabetes, and just any medical problems your parents and siblings and relatives have. Kind of have an idea, because some of these things are hereditary. Next slide. I don't know how to, you can advance to the next slide. I don't know how to do it. You have to do it myself. We talked about 1 in 8 men, 2 cause of cancer death in men. The key with prostate cancer, though, is you'll never find it if you don't screen for it. And if we screen for prostate cancer and find it early, most men can be treated, cured, live a normal life expectancy. The men you hear of dying of prostate cancer most of the time are the men who are non-compliant, who didn't go to a physician. Occasionally, there are men that have a very aggressive, rare form of prostate cancer. That's just bad luck. They didn't do anything to make that happen. But the majority of the cases, the vast majority, are the time if you find it early, we can treat it, cure it, you can live a normal life expectancy. Next slide. So, is it higher in African-American men? You will hear a lot of people say that. It probably is, but with a caveat. What we think is that we have not nailed down the pathophysiological reasons why African-American men may have higher incidence of prostate cancer. But what we do know is our community has less healthcare access. We also have a little bit lower trust levels for healthcare, given the history, for obvious reasons. And because of that, it's found a little bit later and a little bit more advanced stages in African-American men, and that leads to the lower survival rates. So the biggest key is healthcare access, trusting and finding a physician you can trust. Next slide. So we'll skip through this one, kind of go to the next one. We don't need to go. I don't want to get too technical on this. We don't know what causes it. We think a healthy diet's probably going to help decrease your risk of prostate cancer, but the data has not been meshed out. We do know that obese men have a higher incidence of prostate cancer and may actually get more aggressive prostate cancer. Smoking, we're not sure about. Next slide. So we talked about the lifetime risk, 20% for African-American men to almost 21%, and about 18% for whites. So not far off. We're not sure exactly, again, those numbers differ for varying reasons. And so it's probably pretty equal. Next slide. We'll go through this. So, there are different treatment options. And if you get treated, you'll definitely live a bit longer. There's prostatectomies, radiation therapy. Nowadays, we can actually look at the DNA of these cells and determine if a man has the aggressive form or the non-aggressive form, and if it's okay to just watch it. We are getting closer to what's called gene therapy. You will hear about this, where by looking at DNA of the cancer cells, not only can we determine more specifically how aggressive it is, but also determine which treatments will work better in some cancers. So that's the future. The very near future is coming, where we have gene therapy and we can determine what your best treatments are based on the genetic and DNA characteristics of these cells. Next slide. The good news is, when we find it early, men do well. And you should not have to die from prostate cancer. And that disparity between us and the dominant the white people or Caucasians is closing. So we are getting better access and better education to our people. Next slide. So early detection is the key. Every man over 50 should be getting a prostate exam once a year and a blood test. It's important to get both. Some men will say, if we do the blood test, can we skip that finger in the butt? Well, the problem is you will miss 15% of men that way. We find 80% of the cases just from the blood test. But 15% of the time, that blood test is normal and the exam is abnormal, and that's how we find them. So I know no guy wants to remind his doctor to do the digital rectal exam, but it's important that you have both. So your family doctor can do these. There's free screenings. The PSA blood test is pretty readily available. It's 0 to 4 is normal. We've actually gone back to the normal range of 0 to 4. Next slide. Oh, I also want to mention, if you've got a family history of prostate cancer and a first-degree relative, you should start at age 40 being treated, diagnosed, or screened once a year, because there is a higher incidence. Most men are diagnosed after age 65, but we're screening men earlier, so that's drifting down. The typical age range is early 70s is when we diagnose these men. And actually, some men in their 40s actually get diagnosed. So that's why it's important to not take this for granted. Next slide. Let's kind of skip through some of these. I want to get to some of the other conditions. The gold standard is PSA still. We talked about that. It varies by age. Once you're in your 80s, there's a question of, should we check and try to find prostate cancer or not? There's an old adage that sometimes the cure is worse than the disease. And so if you get into your mid 80s, probably you will not die of prostate cancer. You will die of something else. And so the treatment and the diagnosis may be more risky for you. But to diagnose it, it starts with prostate biopsy. It's an office procedure. It takes about 10 minutes. Occasionally, we will use MRI imaging to guide our biopsy. And that's, again, on a case-by-case basis. Next slide. There's no signs and symptoms of prostate cancer. That's a common question. What do I look for? What should I feel? Early stage prostate cancer is asymptomatic. And it's important. That's why screening is so important, because your body will not tell you if you have prostate cancer. And by the time your body's telling you things, it's too late. It's either metastatic to the bones, you're starting to lose weight, it's metastatic to your lymph nodes. That is advanced prostate cancer. And so some of the tests we will get will be like a bone scan, PET scan, things like that. Next slide. So really the important factors are, how old are you when you're diagnosed, extent of disease, and we do all that in the workup. Keep in mind, prostate cancer treatment has some side effects. Potentially it can affect sexual function and or urinary control, but it depends. And it depends on what you have. Removal, more urinary control issues, more erection issues. Radiation therapy, less so. So, we try to select the right treatment for the right patient, and we look at how old you are and the comorbid factors, because really we should take all those into consideration. Next slide. The big thing now is active surveillance. Let's go back one. Because we're able to do DNA analysis of these cancer cells, we find out some men have what we call indolent or slow-growing cancers, to the point where they're so slow you can just watch them, especially men in their 70s, and they never have to worry about it. So older men, sometimes we just prefer observation. If a man has greater than a 15-year life expectancy, and I know none of us have a crystal ball and can say exactly when our time is going to be, but we can make predictions, then that man should be treated, because prostate cancer has a chance to shorten that man's life if you don't treat it. But a guy in his mid 80s, you may just be able to just do nothing. Next slide. Radiation therapy is very common, has this general same outcomes as surgery in early detected men, with a lot less side effects. You don't have the urinary incontinence. You're not wearing diapers. Your erectile function is preserved a lot more with radiation therapy. So finding it early gives you more options and allows you to have a better say in what you're going to do and have less morbidity. Next slide. Nowadays, with prostate removal, the surgical robot is what is used. So outcomes are better, urinary control better. erectile preservation, better, but still there. Next slide. You'll hear a bit about hormonal therapy, like blocking. So let's back up. Like breast cancer, prostate cancer is what we call a hormone sensitive cancer, meaning if you block certain hormones, you can make the cancer not grow as fast or go into remission. Well, if we block a man's testosterone with a shot we give a man twice a year, we can put it into a dormant phase. And a lot of times in our elderly men in their 80s, that's what we'll do just to avoid all the bad effects of surgery and radiation. So again, we have to take all these things into consideration. What's a man's sexual function? Can they tolerate the treatment? If you block a man's testosterone, you will not be sexually interested. You'll start to get hot flashes like when a female goes through menopause. And some men will go on to develop what's called gynecomastia or male breast formation. And over time, our bones become weak when we have low testosterone. So there's things we do to try to prevent weak bones and therefore higher risk for fractures. Next slide. So let's talk a little bit about prostate enlargement. Next slide. This is something all men are going to get. And if you look as the population has aged, we have a lot more people over time. People are living longer. Although I will say this current generation is the first generation that has a lower life expectancy than their parents. So that's a bad sign. That means, people, our diets are terrible. There's too much sedentary lifestyles. People aren't exercising, or smoking and things like that. But this is it's a sad trend that our kids will live longer than their parents. Next slide. So the prevalence of prostate enlargement by age would naturally be higher as you age because it is a disease of aging. Next slide. This is just a cross section. Won't mean much to most of you, but this is what a prostate looks like once you take it out and you cut it. The little channel in the middle is the urine channel, and these little nodular circular things are the glands that get enlarged and they impinge on that urine channel, and that's what causes the urinary symptoms. Men will complain of getting up at night to urinate, a little delay getting started, dribbling at the end, stopping and starting of the stream. And if you ignore those symptoms, it can progress to where you cannot urinate at all. And that's called urinary retention. And that'll get your attention in a hurry, and you'll end up in an emergency room. The part you see where it says peripheral zone, that's that rim at the bottom. That is where 97% of prostate cancers occur. So that's why when we do the prostate biopsy, that's the area we focus our biopsies on. Next slide. So we talked about these symptoms, getting up at night. Don't ignore these symptoms, weak streams, starting and stopping. If you're having these symptoms, mention these to your doctor because it's important. It can help protect your bladder long-term and also help protect your kidneys. Keep in mind, your kidneys depend on your bladder functioning well. And when your bladder doesn't function well and you're not emptying, your kidneys will then can suffer from that. And there have been men develop kidney failure from not emptying their bladder, retaining too much urine and so forth. And also there's more urinary infections in men who don't empty their bladder. Next slide. So we talked about this, complications of this, kidney failure, urinary tract infections. You can get bladder calculi or stones. Hematuria just means blood in the urine. These are all very important things. If you have any of these things, it becomes more critical to have some sort of intervention for your issue. Next slide. Typically, when a man comes in, we're going to measure how well they empty the bladder. It's a painless test using an ultrasound probe on the belly. Sometimes we'll actually do an ultrasound of the prostates, and occasionally we will have to look inside a man's bladder with a little small fiber optic scope to check the health of the bladder and the severity of the obstruction the prostate's causing. That's what cystourethropy is. Next slide. Typically, medications are what we start with. So we don't just jump right in and do surgery for men with prostate enlargement. We'll give, everybody's heard of a medicine called Flomax. That's what's called an alpha blocker, alpha adrenergic blocker. And then there's a drug that can help shrink the prostate too and make it a bit smaller, make it about a third smaller. And so sometimes we will combine those two. Next slide. There are some surgical treatments. Nowadays, these are all outpatient procedures, anything from looking in and resecting prostate tissue to lasering the prostate tissue. And now we have a procedure called aquablation that uses high pressure water jets to ablate tissue, and it's robotic assisted and image guided. So that's really the state of the art. And I've been doing these aquablation procedures. We started them at Riverside several months ago. And that is really what we would call a state of the art treatment for, and it helps to preserve sexual function as well better. So we have some very, very effective treatments for men. Next slide. You will read about or hear about herbal therapies. They're generally not thought to be particularly effective. They're harmless. And so when men tell me about these, I say, well, you can try it. It won't hurt you. There's a good chance it won't help you. And so some men swear that it helps them a little. I would be cautious and just be connected with a physician as you're doing this. Next slide. Let's go to our next slide. Now, let's go forward to our testosterone, because I want to talk about that for men. So let's go to the next slide. Let's see. We'll talk about erectile dysfunction, because 50% of the men in their 50s have erectile dysfunction, 60% of men in the 60s, 70% of men in their 70s, and so forth. You might wonder, why is it that it's higher with aging? And the mistake is to think it's because of the aging. It is not. It is because as we age, medical conditions start to take their toll. High blood pressure, high cholesterol, diabetes, smoking, neurologic issues. So those are the reasons for erection problems with aging. If a man takes care of himself, I've got 80-some-year-old guys who come and get their Viagra prescriptions filled faithfully, or Cialis prescriptions filled faithfully. They're still sexually active. I even have some men in their 80s that still have normal erections without help. What does happen with aging is you can't have the time frame between the ability to reach climax, that's called the latency period, that gets longer. And so when you were 20, you could have sex 3 times in a night, have 3 orgasms. But at age 75, you might only be able to do it once in a night. And then at certain ages, maybe every couple of days. So that's what changes is with aging, is the latency period. Next slide. This is a little pie breakdown of erectile dysfunction. This was a classic study, the Massachusetts male aging study, where they looked at men between 40 and 70, and it was a well-powered study. They had almost 3,000 men. And what they found was over half of these men had some degree of erectile dysfunction, whether it's minimal, mild, or complete. So when a man comes in, I don't just say, do you have erection problems? I have them define it for me and tell me the severity. Typically, men become bothered when they can't penetrate. Okay, if you can get erection firm enough to penetrate, most men they can live with that. But when you can't penetrate, that's when it's, they become very bothered. Next slide. Now, this just shows you that most men don't even seek treatment. Only about 10 to 15% of men go to the doctor, try to get treated. A lot of these men feel like they should just live with it and it's just their fate. And that's sad, because it doesn't have to be. I mean, the treatments for erectile dysfunction, I tell a man, we can make every man short of a corpse have an erection through some means. So there's a way to make it happen. The question is, how motivated are you? Next slide. So what causes erectile dysfunction? We talked a little bit about this. High blood pressure, diabetes, heart disease, those are the most common. Some blood pressure meds. Alcohol abuse, yes. Mild to moderate alcohol intake, generally not. Smoking for sure, because smoking damages micro blood vessels or small blood vessels, much like smoking causes all kinds of other diseases throughout our body. One of the worst things a human can do to their body is smoke. If I could stop one thing, it would be smoking, because you would reduce cardiovascular disease. You would reduce numerous cancers. You would reduce so many illnesses just by eliminating smoking. Next slide. So stop smoking. Alcohol intake should be moderate to limited. Healthy diet, exercise. These are all things that help keep you healthier. And by staying healthier, you can maintain erectile function. Next slide. Viagra is in this category of drugs, what we call a PDE5 inhibitor, phosphodiesterase 5 inhibitor, Viagra, Cialis, Levitra, Stendra. These drugs, several of them, Levitra's now generic since I made these slides. You can get these for $1 a pill. So the cost factor is not really a factor anymore. With GoodRx, you can get Viagra, Cialis, Levitra, all of these things for about $1 a pill. So they're very, very affordable. Next slide. This is just what it looks like. It's a vacuum erection device. These are now available over the counter and on Amazon. You don't need a prescription. It uses physics to pull blood into the penis, and then a constriction ring to help hold the erection. YouTube University probably will show you how to use anything. Next slide. In some men, we have to go to using injections, where we show you how to give yourself a shot in the side of the penis. It sounds terrible, but there's not a lot of pain fibers there. And what you can expect is about an 85 to 90% success rate with these injections. So they're very effective, affordable. Typically, you're going to want to be coached and trained on how to do this initially by your physician, by your urologist, and then you do these injections at home. Next slide. In some extreme cases, men opt to have a device implanted into their penis where they have a pump in the scrotum that you inflate these little cylinders that are implanted on the inside. And that's called a penile prosthesis. Again, very effective. Nowadays, we're able to do these generally as an outpatient surgery, and men are very happy with it. Next slide. Low testosterone. This is important because you'll see lots of commercials about this. And I think men should ask to have their testosterone checked because it's very common. It does increase with aging. Obesity has a higher incidence. And men that are on chronic pain meds can have lower testosterone. Next slide. The symptoms are, again, it's not just sex drive. That's what libido is. But if you have tiredness and fatigue, and it seems to be out of scale with your exertion, that could be related to low testosterone, loss of muscle mass, sleep disorders, cognitive fogginess, brain fog. All of these, mood lability, a labile mood, all can be tied to testosterone. And it's a fairly easy thing to treat. Next slide. It's a blood test, fairly simple. We like to do it in the morning. Testosterone is one of those hormones that has what's called a circadian rhythm, and that has to do with time of day. We think it has to do with the whole hunter-gatherer thing through evolution, where you got up and you went out and hunted food for the family, so you needed that higher testosterone in the morning. But it does peak in the morning. We can do topical therapies where you rub something as simple as rubbing a gel on your skin, to injections, to testosterone pellet implants. There's a new oral thing that's out. It's very expensive, but it's not covered by a lot of insurances. But there's an oral treatment for low testosterone now. Next slide. Typically, once a man is on testosterone, we want to monitor your blood work about every 6 months. We'll check a testosterone and a PSA every 6 months. Now, testosterone use does not cause prostate cancer, but if you have prostate cancer and it has not been treated, you do not want to use extra testosterone because it can stimulate the cells. But if you have testosterone, it's been treated and you're cured, it's safe to use testosterone therapy. We also will periodically check liver function tests. It can make you make more red blood cells, which under normal circumstances is a good thing. But if you have too many red blood cells, your blood becomes a little bit too viscous, a little too thick. And we'll have those men donate blood at the Red Cross or something if that happens. But that's fairly rare. Next slide. So I talked about this. Does not cause prostate cancer. You can use it if you're cured. But generally speaking, a very safe treatment. Next slide. Your primary care doctor can help you with a lot of these things. The bottom line is you should see your primary care doctor at least once a year. And that's if you're healthy. And if you have health challenges, you need to see them more than once a year. I think a healthy lifestyle, meaning a healthy diet, low in processed carbohydrates, with eye on caloric, don't get crazy with too many calories, and exercise.
Yes,
those are the key. Good habits, develop these habits young. If you have kids, healthy kids have a better chance to be healthy adults. Obese kids are typically going to become obese adults. So you want to adopt and foster healthy eating and exercise habits in your children when they're young. Avoid smoking. No one needs to smoke. There's no health benefits to smoking. And if you are going to have alcohol, I would say definitely moderation is the key. So I think that might be my last slide, and I'm happy to open this up and answer any and all questions anyone has. If anyone has questions offline, they can contact me through email. So if there's any questions, I'm happy to answer.
Let's first of all thank Dr. Ward for carving out time for us to share that information. Appreciate you, brother.
Thank you. My pleasure.
I will say to this group, Dr. Ward is my specialist. And I think, Eric, maybe about a month and a half ago, you guys, I had my second annual
Right.
checkup.
Hello.
And I came out of that with the doctor saying, for all practical purposes, I was cured. For some of you, I think you know, I want to say it was 2019 when we first discovered prostate cancer. Um, and I'm a processor, so I needed to think about it. And Dr. Ward very candidly, but in his humor kind of way, said, "Well, look, man, you got in here early enough. You're going to die, but it won't be from this." So he gave me several options to consider and encouraged me to talk to other folks, interview some doctors, and to identify what form of treatment worked best for me, given my lifestyle and schedule. And I think Dr. Ward at that time, CyberKnife was fairly new, I
Right.
want to say, to the market. But I chose that method. And it absolutely worked for me. And again, I thank God and for those who were around me, where early detection was absolutely the key. And so it's one of the reasons why I wanted to sort of kick this series off for the summer with Dr. Ward. And some of you I can see on the screen, and there's numbers of you who are not on today, but I know have approached me personally about trying to get more information about this situation. So we thought it important to kick off with this conversation. It doesn't mean that we can't revisit it. And certainly my hope would be that in 30 days, you guys will encourage others alongside of yourself to tap into the one about nutrition. And then 30 days after that in August, we'll hit the one about fitness. So just wanted to give you that context. That early treatment is critical. And my son, who is only, I think Amon just turned 34. And Doc, I just heard you mention that at 40, you should start encouraging certainly those in our lives to make sure they get checked out. But I put him on to it. And what was great about going through Dr. Ward, man, that family history is so important.
Yeah.
There were things that I just did not necessarily know about my dad, my grandmother, and my uncle, our Uncle Frank, who had all experienced this. And had I known early on, I probably could have even got it detected early on. So spend the time, man. Talk to the other men in your life to make sure that you absolutely have a better handle on your family history is critically important. So I just wanted to share that context with everybody on the call.
Thank you. Yeah, and a lot of our parents and grandparents were fairly stoic, right? And
Yeah.
I mean, my dad would suffer through things. He wouldn't tell us anything. You had to drag it out of him. And I think we just have to be persistent. And the reason to know is because some of these things are hereditary.
Right.
And if you can know about them early, 85% of high blood pressure is what's called essential hypertension, and it's probably hereditary. Cholesterol, your lipid profile you inherit. It's not diet. And that's why diet by itself never fixes cholesterol. Diet and exercise can do some things, but diet by itself almost never works. And so, but knowing your family history is important, and also get a physician that sees you and recognizes that there may be some differences in African Americans. And, there are some things that happened to us during the middle trade, during slave trade, and the way the survivors, we think that our hypertension is different because the survivors of the Middle Passage were the ones who could retain fluids better and not get dehydrated and die. And therefore, we are more fluid retainers. And so our hypertension, that's why African Americans get put on diuretics even more, because you can have hypertension from too much fluid in your system or vasoconstriction or both. And that's why there's so many different hypertension treatments, because you have to find what works for that patient. And so I'm not saying everybody needs an African-American primary care doctor. There's not enough out there for all of us, but you just need to make sure you know your health, understand these differences, and be engaged with your healthcare providers. Don't just let them tell you stuff. Do your own research. Ask questions. If they're offended by you asking questions, you need another doctor, because then it becomes about them and their ego. I mean, people can ask me as many questions as they want. They can do their own research. I'm happy to have people get second opinions, because it ain't about me. It's about you. the patient. So
Appreciate that. Landon, it
Yeah,
looks like there are some questions maybe in the chat.
there are. Yep. Dr. Ward, one question. Can you reduce the size of your prostate uh, if you have a benign large prostate condition? Can it turn into cancer?
So the answer is yes. You can reduce the size of your prostate with medication, not naturally. Because remember, we're genetically programmed for certain organ size and risks and things. And so, yes, there's a medicine called, well, finasteride is one and dutasteride is another. Those can reduce the volume of your gland by about a third. It doesn't necessarily reduce your risk of prostate cancer. We don't think it increases the risk of prostate cancer. So the risk of prostate cancer is separate from enlargement. But yes, there's medications that can reduce the volume of the prostate.
And how many times, if any, should you get up at night? And if you are, what number should be concerning if you're getting up in the middle of the night to use the restroom?
And that's a great question because nighttime urination, believe it or not, is one of the more bothersome symptoms because it affects your sleep. And, you know, you don't have a lot of other stimuli going on. So it gets your attention when you're getting up to pee. But keep in mind, there are a lot of factors, there are a lot of variables. Some people don't sleep well. So if you're not sleeping well, some men are going to the bathroom because they're awake, not waking up because they have to go to the restroom. Sleep apnea. If you have sleep apnea, those men, they'll come and go, I'm getting up 4 times. And as soon as they get a CPAP, they don't get up or they get up once. So really, it was because they were awake. They're going to pee because they were awake, not vice versa. And so how much fluids do you drink in the evenings? And if you drink diuretic type fluids like alcohol and caffeine in the evening, those will make you make more urine when you lay down. So again, there's a lot of factors in nighttime urine production. We don't sleep soundly as we age. So the sleep studies are showing that as you age, you wake up more. Now, you may not wake up well enough to be completely lucid or get up, but you're awake enough that a stimuli like something like your bladder being full will lead to you feeling like you need to go to the restroom. So it's a tricky question to answer. There's really no normal amount. Obviously, we'd all like not to get up at all. But if you're getting up once a night, that's probably not too out of bounds. I would say if you're getting up 2 or 3 times a night, okay, maybe it's time to have a conversation. If you've tried reducing your evening fluids and things like that.
And can you or
Can or do.
Can or do insurance companies determine medical treatment options based upon your life expectancy, age, and those sort of things?
Fortunately, they have not done that. They have not said, oh, this man's too old for this treatment and things like that. So no, they typically don't. Now, they are gatekeepers in that they cover some medications and some they don't. They cover some procedures and some they'll call experimental that aren't. And so we have to jump through those hoops and deal with those hurdles as we come to them, but they don't base it on age. I think that would be they get challenged pretty hard in the courts for that.
Other questions for brothers on the call?
Sure.
So I was just wondering, is there if your PSA is increased from the last time you got it, and you're doing it yearly, is it like a doubling of that should cause a concern? Is there some equation that we should be aware of that?
Well, that's an excellent question, and you are alluding to something called PSA velocity. And that's the rate of change. And we do look at that. So this is where knowing your numbers and knowing the trends, are important. So I try to encourage men to keep all their numbers and graph it. make a little, graph date, PSA, and draw lines, because the rate of change is important. You are correct. If your PSA was 1 this year and 3 next year, and even though it's less than 4 and considered normal, we don't like to see that kind of rate of change. The accepted change in a year is 3/4 of a point. Now that's published in the literature with some leeway, but you're correct. Rate of change is important. And so it's not just important to know that it's within normal limits, but what has it been? Because if it's been at a certain level relatively, and then all of a sudden there's a big jump, then we get concerned, and we'll do biopsies for that. Just to specifically speak to President Biden's situation, the medical community, there's been some stuff leak out that perhaps he wasn't getting checked. They thought maybe because of his age, but I don't know that he was getting digital rectal exam and serum PSAs. And he was not, something happened there. They're not going to tell us. But the theory in the urological community is that somehow they dropped the ball, or he decided, okay, I don't want to get checked anymore, or whatever. You would think that'd be impossible for a president, because what the kind of cancer he has is very aggressive. And that gets to, it takes time for that to happen. It usually doesn't start out that way. Cancers evolve. And once you get to the aggressive point, it'll likely shorten his life. There are some treatments that may extend it a bit, but it's not a good situation for him.
Yeah, I understand. Thank you.
Any other questions?
There's one that Landon, I don't know if you just saw this one or maybe was asked. It says, is it true that—
And if you're putting pressure on that area, you are putting pressure on your prostate. So a long car ride, a bike ride, exercise bike, sitting on any kind of saddle, yes, that can affect your number. So I tell men, try to be hydrated, try to avoid intercourse and sitting on a saddle or anything for 48 hours before their test to get the best number.
Thanks, Doc.
Yes. Oh, other things I want to add. Prostatitis, we didn't talk about that in our talk. Itis on any word means inflammation. So when you see dermatitis, arthritis, whatever, that just means inflammation. So prostatitis means inflammation of the prostate. That can cause your PSA to be artificially elevated as well. And a man with prostatitis will many times complain of discomfort in the penis, achiness in the scrotum or the belly, lower belly or lower back. If you have any of those symptoms, you may have prostatitis, and that can be treated. An antibiotic and an anti-inflammatory will help that, but you don't want to get a PSA during inflammation. So.
Beautiful. Don't know if there are any additional questions. I'm not seeing any additional ones, at least in the chat so far. Let's see.
No, I think we're all clear in the chat.
So if you get any more, if someone watches this on YouTube, feel free to forward those on to me through my email. I'm happy to reach out to people and reply, at any time. Anything we can do to educate our community, certainly our congregation, is something we should be doing as much as possible.
Beautiful.
Any advice for brothers? I know a lot of the sort of not quite stigma, but people don't want to expose their bodies. They don't want the rectal exam. What do you mean I might have to wear a diaper? Can you talk to how you talk men and patients through those things? Those are real concerns on the front side. They're real barriers for people, real things that people kind of deal with or confront with. Any advice or just encouragement to men and patients that you give them?
Yes. Well, what I would tell men, the digital rectal exam, I explain why it's important. Because 15% of the time, even with a normal blood test, we find a nodule or something abnormal, which warrants a biopsy. The other thing I explained to them, that this exam takes about 4 or 5 seconds. It's a very short exam. There's lubrication on the finger. If you can have a bowel movement, you can have a rectal exam. Now, obviously, it's going the wrong way on a one-way street, but it's only for a few seconds. And so that's how I explain it to them. I haven't had a man yet tell me, hey, I'm absolutely not doing that. Now they'll say, hey, I've got diarrhea today, I'm not doing it, whatever. But, generally speaking, you can get them to accept it. With regards to potentially having to wear a diaper after certain treatments, that's a reality, but I explain it to them that it's extremely rare. Long-term urinary incontinence is very common. And so that's unlikely to happen. But this digital exam is important. And also, I remind men that women have babies, men don't, which is way worse than the digital rectal exam. I remind men that women go get pap smears and mammograms. Just have your wife describe to you what that was like, and that'll make you, a little less queasy about getting a digital rectal. There's worse things that can happen to you.
Very fair. So, I was in labor and delivery with my wife when she had to have her cervix checked.
Yeah.
And she had a what's it where they give you they give them the shot in the back.
Epidural.
An epidural. And so she couldn't feel. And I remember watching the doctor's arm disappear.
Yeah, exactly.
And my wife not understanding what was happening. I thought, this is not going to be nice if she understands what's happening and she can't. Yeah. So that's a good context to put it in.
Yeah. So our wives go through worse. So it's a very short. If things are normal, you only need it once a year. That's the other thing.
Yeah.
Once a year, we can get ourselves kind of ready for that. We can get ourselves hyped up to get that once a year and get through it.
And then Brother Boxell's got a question about September being Prostate Cancer Awareness Month. Does Ohio Health have any particular screenings or pre-screenings?
Not that I know of. The African American Male Wellness event, the walk, Ohio Health will be participating. Ohio State will be participating. We're trying to bring back, they do with the PSA blood test. We don't think we're going to be able to do digital exams. Just the logistics of that's kind of tough for that many men. But kicking that around. So I'm going to try to attend the next planning meeting. But that's coming up in early mid-August. So I would encourage men to come out. I mean, good event. They do blood pressure, blood sugar, PSA. We're trying to get PSA back this year. And that's one of the things you can do. I'm not sure of any specific screening events that Ohio Health is having outside of that. Mm-hmm.
All right. Well, Dr. Ward, thank you again for
being
with us today.
My pleasure.
It's rich information and knowledge. We are looking forward to our next, trying to pull up our next episode will be Wednesday, July, watching us today. And he's going to lead us through some exercises, how to do quick watching us today. And he's going to lead us through some exercises, how to do quick 15-minute workouts to keep your body moving. Any movement is better than none. If you have questions or thoughts or some things you'd like to make sure that we cover in those next two episodes, or for another part of series that we might lift up, don't hesitate to contact myself or Brother Adam Troy, our Director of Missions, who we are leading this effort together. Brother Adam, anything for you as we close out today?
No, just appreciate you brothers carving out the time to invest in yourselves, essentially. So spread the word to invest in yourselves, essentially. So spread the word. Make sure that...
Guys, I'm running to surgery. They're calling me into... They can't start without me, though. So they just want...
All right, everybody. Have a great rest.
Thanks.
Take care, guys.
Appreciate everybody. Take care, brothers.